All right. Good afternoon, everyone. On behalf of our Take Heart team, I'd like to welcome you to today's session. We do hope that you are having a wonderful start to your summer season thus far. In the interest of time, we've got a jam-packed session today. I'm going to run through a few reminders, and then we'll go ahead and get us kicked off from there. So on the next slide, today's session is the 9th out of 10 sessions for Take Heart. Just as a quick reminder, this is the third of 3 sessions in our series on care coordination. As in the past, we will have the training session today that is led by and moderated by select experts in the field. And then following today's session, you'll see by email the implementation guide that's associated with this module. That has helpful tips, has some resources for you, and then we really look forward to having you join us at the partner hospital peer action groups that follow. On the next slide, as with all of our trainings, hopefully folks have taken advantage of this, but if you haven't, you still can. As with all of our training modules, we do have CEUs available for today's session. Email instructions will follow the session in the next day or two, so you can take advantage of those CEUs. They'll be sent to all participants who've attended the session. And then just one last reminder, we very much enjoy hearing from each of you during the session. And just a quick reminder that if you're interested in chatting, you can go ahead and use the chat function that can be found towards the bottom of your screen. Our big ask of you is that you go ahead and set the chat function to everyone so that we can all see your question and be able to weigh in as part of the discussion. All right, and with that, thank you again so much for joining us today. I'm going to pass you over to Steve Hine.
Thanks, Cynthia, and good afternoon, everyone. Just to contextualize the discussion today, this is the third and last of the focused sessions that address care coordination issues. So if you recall in Module 6, we talked about preliminary work to get ready to enhance your care coordination. And then in Module 8, we discussed substantive changes that you could make to care coordination. And then today, we're really focused on how you can activate your patients, because activating your patients is absolutely essential if you're going to be able to work with them to coordinate their care. So as far as our learning goals for today, we want to help you better analyze patient and hospital case studies so that you can understand techniques for activating patients. And then we want you to be able to apply some lessons learned through those case studies to gaps in your own cardiac rehab program's care coordination workflow. Every care coordination workflow has opportunities for improvement and for better activating patients. And today we really want you to learn how. Now, today's session addresses this. Let me introduce our speakers for it. Simone Bailey-Brown, Adam Streb, and Kathy Duckett will be sharing in recorded parts of the video today, and as well as Tara Rouse. And then we're also very happy that Lucia Izzo has joined us. Lucia is an administrative supervisor at Hackensack Meridian Health and has extensive experience with this. So I'm just going to ask Lucia to briefly give us a quick overview of your program, as well as how you reacted to the care coordination discussion of patient activation when you were going through this in an earlier time.
Sure. Thanks so much, Steve. I had an excellent experience with the Take Heart program. I work at a fairly large hospital, 781 beds. My cardiac rehab has been around since the 90s. I've been here since 2002. We see 350 to 400 patients a year. The hospital is one of the top 50 in cardiology and heart surgery, so they definitely focus on the heart and vascular. Hospital is definitely forward. However, we kind of work in silos until I got involved with this care coordination. We did the best we could as far as care coordination, setting letters to patients post-CABG, post-cath lab. We initiated a phase 1 program. We do visit MD doctors' offices. We send brochures, prescription pads to the offices. We round on the patients. So we did have a program set up. However, based on, I'm sure, everybody's cardiac rehab, our resources are very limited, so there were time, it was difficult as far as time. And we really didn't feel like, although we are part of the Heart and Vascular Hospital, we really didn't feel like we were on the team, but that has certainly changed. I think everywhere also is, money makers get more attention than the money savers, and we know cardiac rehab saves a lot of money with reducing readmissions. However, the focus has not been on us. So we're working to change that. I was limited in my ability to get an automatic referral because we're not on the EMR. And so we're not really recognized as much by other team members as we should be. But that's a work in progress as well. Down the road, hopefully we get there. But we have made a lot of great changes. We have a cath lab champion now that's working to get the docs to write prescriptions right, especially for the same day PCI patients. Our data is presented in our Heart and Vascular Hospital monthly reports. And we initiated an e-learning for all the staff. Every appropriate inpatient nurse is going to get an e-learning that she has to do on cardiac rehab so that people will know who's eligible. And then we can all be talking, saying the same thing about the next step. And our Heart and Vascular Hospital leadership is also starting to track doctors and who's referring and who's not referring.
All right, thanks very much, Lucia. And to our audience, we want to encourage you to submit questions, comments into the chat. We'll take some time at the end and respond to those questions, and Lucia can provide her candid assessment and very practical advice to you. Now, as a reminder, care coordination is not just what you do between when somebody's identified on the floor as potentially needing cardiac rehab and the time that you get them into your door for the first session. Care coordination, it really involves the whole process going from phase 1 cardiac rehab all the way through phase 3 maintenance. At each step of the way, care coordination can help keep the patient engaged and enhance the outcomes. And it doesn't just involve a single person. Even if you have a dedicated care coordinator, really every person that's involved with the patients directly or indirectly needs to view themselves as facilitating the coordination of your patients. In terms of a patient-centered approach to care, this is really the focus of today's session, and that is including the patient and the family in the discussions, tailoring the care to be culturally sensitive, educating the patient and family using plain language repeated frequently, if necessary, about the patient, their condition, how the process works, and then really listening, not just, answering questions, but really listening and trying to be perceptive to understand what the patient and the family want out of it and what confusion they may have that you can help them to sort out. So having said that, let me turn it over now and we'll start to listen to Kathy and her assessment of this and the distinctions between patient activation and patient engagement.
Well, before we get into the case studies, we're going to talk a little bit about the theory behind the difference with patient activation and patient engagement. Because patients have to be activated in order to meaningfully engage in their own care for clinical services to be truly effective. And patient activation is a measure of an individual's understanding, competence, and willing to participate in care decisions and processes. And so this becomes a key component in treatment. And we're going to talk a little bit more about what understanding, competence, and willingness is for the patients and what each of these means. It's different than patient engagement. Patient activation is the level at which patients are ready to participate in their own care and self-manage. They have low levels and high levels of patient activation. That's how we've divided it. And knowing which level your patient is at is important, because it determines how ready the patient is going to be to utilize the strategies aimed at increasing their engagement. So we have a brief survey tool, such as the Patient Activation Measure, or a PAM, P-A-M. It's also known as the PAM measure, and it can be used to determine the patient's activation level on on the beginning of your program. A low activation level may mean the patient isn't ready to participate in their care, whereas a high activation level may mean the patient will need less active staff management as they're already actively interested and they're already ready to become engaged in their care. Patient engagement is defined as the desire and capability to actively choose to participate in their care in a way uniquely appropriate to them as an individual in cooperation with their healthcare provider or institution and for the purpose of maximizing outcomes or improving experiences of care. And more information on the PAM tool is found in your Module 9 implementation guide. So patients who are more activated or are more involved in their healthcare tend to have better health outcomes, makes sense, right? And lower costs than those who are less activated. A meta-analysis was done by Dr. Hibbard that included more than 180 peer-reviewed articles, which determined that these commonalities existed among highly activated patients. And I want you to look at the second bullet first, because highly activated patients get more out of their care. So they're ready to become engaged and be actively involved. And because of that, they end up to be more participatory in terms of making sure that they have positive health behaviors and then, of course, then have better health outcomes. And all of this results ultimately in lower healthcare costs. The other thing the Hibbard study showed was that there are 4 stages of activation. And activated patients, first of all, already believe that they have an important role to play in their own healthcare. They're already ready to be engaged in their healthcare. And because of that, they are ready to develop both the knowledge and the confidence, because they need both. People always need knowledge and they need confidence in their ability. If you have the knowledge but you have no confidence, you're not going to succeed. And if you have a ton of confidence but you don't really have the knowledge that you need in order to succeed, you're not going to succeed either. So you need both. They need to take an active role in their healthcare, including an understanding of how to access, and this is important, how to access and use the healthcare and supportive services. This then translates into their confidence and knowledge to take the information into action, which is what I was talking about. You have to have both. And then because of this, they're able then to maintain an active role in their healthcare, even when they're faced with challenges. So they're highly activated, highly motivated. So what do they need to do? There are 6 core tasks that support activation. And when you're building your program, you're going to want to make sure that you're including these tasks. The symptom self-management, that is symptom education, is definitely built into the programs. We want to make sure that they're engaged in actions that support health and functioning. And we may need to teach them what that is. We want to actively involve them in their treatment decision making. We'll talk a little bit more about what that means. Collaborate with healthcare providers, because they're not passive participants, they're active participants in their care. Performance-based selection of providers. We want to make sure we have the right people at the right time helping them. And then how do you navigate the provider system, which we know can be a very, very complicated structure for people it can be complicated for us, and we're in the healthcare system. It becomes really complicated if you're coming into this because of a life event. And then the question is, how do you build a program that then supports all these tasks? So once you have determined the patient's activation level using the PAM survey, which is, again, just one survey, but it's in with your materials, and I would suggest you look at it. It's a great tool. You want to tailor the extent of the engagement and the types of the engagement tools that you're going to need. So when we talk about extent, highly activated patients, they may not need as much care coordination. You may be able to give them some suggestions, and they're going to go off and do it on their own. An example of that might be that for some patients, you're going to say, read this and then come back and be prepared and let's talk about it. And they're going to go home and they're going to do it. They're going to go home and say, hey, I YouTubed whatever. And they're going to come back and say, or have you seen the latest diet on a heart healthy diet? And let's talk about that. A low activated patient is going to really not have the motivation to go find that information on their own. You're going to use your activation survey then that will help you determine how to build that individual care plan for that patient, or that not necessarily you want to call them patients, but for that person that's utilizing your services, or customer. And then when in doubt, you want to utilize engagement tools that you have available, and utilize that time for the people who need it more, and maybe give more direction for people to do things independently if they're highly activated. So what are some strategies? Here we have a list of strategies that can be found in your Module 9 implementation guide. And these strategies have been shown to assist patients and staff with empowering patients to advocate for themselves while allowing the clinician to understand the nuances of what each patient desires and is motivated to complete on their own. I'm going to point out that on the right-hand side, you're going to see that under motivational interviewing, there's patient goal, active listening, teach back, and coaching. If you're not familiar with the motivational interviewing tools, teach back is that you teach them and then you ask them to explain in their own words their understanding, and that's a great tool to hear back what they heard you say, because many times as we're educating people, we come from our own experiences and our own understanding of medical language, and so we think we're being really clear because it seems simple to us, but it may not be simple. And so when you ask someone to teach it back, you can hear where they may have misunderstood a principle that becomes important that you're going to then build on later on. So if you're not familiar with the active listening, teach back, coaching, all these motivational interviewing tools, a good resource is the Institute of Healthcare Improvement. If you go to ihi.org and you put any of those titles into the search engine, they'll pop up with a lot of resources so that you can learn more about it. And Stephen talked about simple education materials, making sure they're written. We have to be very aware of health literacy and make sure that we're writing information at a level people understand. I often say when I'm writing patient education tools, I've never had someone give it back to me and say, wow, this is way too simple. Do you have something more complicated for me to learn from? People don't ever ask for more complicated stuff, but you can tell when you're doing teach back that there's too much medical jargon and some things that may seem simple to us. So we want to make sure that we're really understanding what their needs are from a health literacy perspective and from an activation perspective, so we can make sure we're giving them the tools that they need. And there's more information about this in the program.
Yeah, thanks very much, Kathy. And before we go on, let me just ask one quick follow-up question. So how frequently do you use both the patient and perhaps their other family member that accompanies them as you work on teachbacks and other things? Because it seems that at least sometimes the spouse or the significant other of the patient may be the person that you really need to work with every bit as much as the patient to understand some of the things.
That's an excellent point, Stephen. I think the challenge becomes with most of the cardiac rehab programs is, are we establishing initially the involvement of the significant other in the patient's healthcare? So the program I was involved with, there were no significant others there. Everybody kind of walked in and said hi and went right to the machines, and we did our own thing. But there was nobody asked me, who cooks in your family? I guess maybe they assumed I did. They would be wrong. My husband does the cooking in my family. But I think that you make an excellent point, and it starts with the pre-survey, right? And so part of our question should be, who else is involved in your life at this point who may be involved in helping you maintain a healthy lifestyle? And then we can actively get them involved in when we're educating in different aspects of the education we need to do for their lifestyle management. Excellent point.
All right, let's turn to a case study now. Tara and Kathy are going to talk about their experiences with cardiac rehab, starting at the referral stage through the participation in cardiac rehab.
And Tara will talk about how she herself became activated to become an advocate because of a far from perfect launch of her own journey into cardiac rehab. And then Kathy will talk about her experience from the perspective of what she would improve through the lens of a quality improvement nurse. So let me turn it first to Tara.
Yeah, thank you. I love all of the content that Kathy shared, and I'm so pleased to be a part of this. So I'm going to give you a little bit of backstory here. So, you hear people joke about how, things go downhill when you turn 40. Well, for me, that was a heart attack on June 4th, 2017. So, of course, I had been, it was one of those rare nights that my husband and I were going out. We did like movie and dinner. We had, thankfully, our kids were with a family member. I had gone to bed, and shortly after that, I woke up with just the most intense pain. It was like vice grip on my arms and in my back. And I was not having chest pain, but I knew enough to know that women often have those non-traditional symptoms during a heart attack. So, of course, I'm laying in bed, and what do? I pull out my phone and start Googling, heart attacks in women. And I still wasn't real confident about what was happening, but I woke up my husband and I said, I think I need to go to the hospital. So when I got there, my EKG was normal, but they moved me up to the cardiac unit for observation to, check on different levels, getting my blood results back and that. So my husband went home to rest amidst all this. I said, go home. You don't need to be here. And of course, short time after that, my nurse came in my room and said, we just got some results back. They found troponin in your bloodstream. You did have a heart attack, and we're going to need to do a cardiac cath on you first thing in the morning. So, of course, I'm terrified. It's too late to call my husband, and called him in the morning. He came in just as they were getting ready to wheel me down. And as a patient, all you're thinking about is, the potentialities of what they might find. And so fortunate, there were no significant blockages at all. And I was very relieved by that, but also so confused. Why did this happen? How can I prevent this from happening again? So shortly after I returned to my room, and that's where we start to get into this referral process, I was met by a PA who I had never met before, and she was writing up my discharge instructions and announced that she would be changing my meds. And so I had been taking one of the meds I'd been taking was atenolol, and that I had been taking that for years to successfully manage my blood pressure. Over a decade I had, but in her words, it was antiquated. And so she was going to take me off that. She was going to take me off my diuretic and was going to put me on something new, and I should follow up with cardiology in 2 days. So the dutiful patient that I was, I switched. I did all of those things, and my heart felt like it was going to beat out of my chest. My heart rate would rise super rapidly, just getting out of the bed and walking, 10, 15 feet to the bathroom, and which of course made my anxiety level feel like a 20 out of 10. So I was so excited to get into my cardiology appointment, hoping for relief, some help, some guidance. And my appointment was with the attending. I didn't have a cardiologist, so it was with an attending who had taken care of me in the hospital, but who I had never met or spoken to. He, when I got there, my vitals were crazy high. He retook them, and here, as suspected, my previously controlled blood pressure was really high. My resting pulse was 115. And I know this, I went back and looked it up in my chart. And I explained to him all of the symptoms I was experiencing and the distress. And he said, well, essentially, you need to lose weight and come back in 4 weeks. The whole appointment, it lasted maybe 5 minutes. And some of that time he spent returning texts on his phone. And so I left that appointment feeling like the best course of action for me was to reach out to a trusted provider who is my primary care physician. So the next week I sat in his office and told him all that had happened. We discussed all the options and decided we'd go back on the medications that had been working for me before my heart attack. But because of the heart attack, we would add a calcium channel blocker to help address what we thought may have been the cause of my heart attack. I explained that I didn't feel comfortable going back to that cardiologist that I had seen. And so my primary care physician and I worked together to identify a new physician who specialized in women's cardiac health for me. So, of course, it took me a month and a half to get in with her. But during that first appointment with her, she asked if I would be interested in cardiac rehab. And she talked about what that was. And I agreed. I said, yes, that sounds great. So while we were sitting in the room together, she got into the online place where she would put orders. And she said, well, you've already been referred. But it looks like they didn't refer you to a specific location. It was just a generic cardiac rehab referral. So my orders had essentially been sitting in this, she called it like this black box with like thousands of other patients who had been referred for something, but more information was needed in order to proceed. So she said, okay, here are your location options. We're going to make it specific. She created a new referral and gave me the information for the rehab coordinator as well, so I could reach out on my own. And so we agreed, we made a plan. I would stay close contact with my trusted primary provider, and we would connect again in 3 months. And I can show you this exciting, my day of graduation from cardiac rehab. So I began cardiac rehab. It took me about 3 months to get in with all those delays after my heart attack. And I was one of the few females and certainly the youngest person in there. I had rehab twice a week for 2 months. And I will say it was so vital to me for building my confidence in this really safe space. When I left, I said, anything you need to do that I can help do to support this program, I will absolutely do. I just, every heart attack patient I've met now, I am like advocating, that they attended. It's so effective and was so meaningful for me. So thinking about that and my experience, I love this model, the Swiss cheese. So as you know, in healthcare and all system, there are always so many opportunities for things to fall through the cracks. In my experience, it was providers who hadn't told me I had been referred, a referral system that providers were not fully educated about, a backlog of orders to be followed up on, et cetera, et cetera. So as you think about building your cardiac rehab programs and referral processes, I would urge you to think about how best to make sure that there are multiple processes in place to ensure that patients are part of the decision-making process, asking about them, about their goals for recovery, and making sure that, if we don't catch them here, we're going to catch them somewhere else. For me, it was bad care that motivated me to be even more involved in my health care. But for other patients, those same experiences I had could cause them to just totally disengage with their patients altogether out of frustration. So just to give you a little insight into my experience, and I know Kathy will share more and connect the dots even more to what she talked about with patient engagement and activation.
Thank you, Tara. And on behalf of all healthcare professionals, I want to apologize because that is the poster for how not to provide cardiac care. I wanted to go over, this is an overview of my program. And before I talk about my impressions as a patient or my take as a nurse with quality and compliance improvement background, I wanted to give you the basics of the program. I also want to say that given the design of the program, I thought my cardiac rehab team did a great job. They were lovely people. I think they did I think they did a great job, but there's always room for improvement. And so I wanted to give you an idea of what happened, and then what I think maybe a better design for a cardiac rehab program might be. So the first thing I want you to notice is that it's available Monday through Thursday, 7:30 to 3:30 p.m. And of course, this matches the day shift time. But the challenge I have is that I work full time Monday through Friday. And I had 8 cardiac caths before I finally had my cabbage. And so each time they offered me cardiac rehab, but with a full-time job and also travel involved in that job, trying to fit the cardiac rehab that is available into what the time that I had just really didn't work. So I ended up going through cardiac rehab twice, 3 years apart. A great deal of the reason is because of this. It's only available Monday through Thursday, only 7:30 a.m. to 3:30 p.m. So that was a big challenge for me. And it's a very small program. I saw all those treadmills in Tara's program. I thought, wow, that's great. That's definitely not my program, but it was a smaller program. We had orientation. Parameters were individualized, but the program was extremely standardized. And they did use videos, but generally what they did was they said, come in, sit down, watch this video, and then we'll see if you have any questions afterwards. They did that with everybody. And there was pretty inconsistent participation during the 3 months, and because I could see all the people who came and went. And generally, the program was really geared toward retired older men. I mean, that really was the way the program was geared. It really wasn't geared to people who had full-time jobs, who had cardiac events. So definitely not a younger cardiac survivor or a cardiac patient. This is the program. The program, it was included a knowledge pre-test. The focus was on my knowledge of my symptoms and lifestyle management, but it was really on what did I know about these 4 areas. And this post test was exactly the same as the pre-test. The coaching was around exercise parameters, increase this rate, increase the treadmill height. Can you go the resistance on the bike, that kind of information. And we would be on equipment for 15 to 20 minutes, and then we take a break and then have to go to another piece of equipment. And part of that was because there wasn't a lot of equipment, and there would be 5 or 6 of us in the room. And so we would need to give everybody a chance to use the equipment. So, but no time was spent on activation activities that I discussed earlier, other than assessing my knowledge regarding my symptom self-management. They never assessed my willingness or ability to independently manage my healthcare. The actions to support health and function maintenance were the video education and very limited group discussions, but there was no individual discussion with me on what treatment decisions should be made, or collaboration in terms of how I would incorporate the changes in my lifestyle, or even what my goals for my care were. Again, everybody was really nice, and I believe they were interested in me, but they weren't given the tools they needed to assess my activation or use those activation assessments and tools to actively engage me in my care, so that I established clear post-rehab goals and understood what I needed to do to achieve them. So what could they have done differently? So now I'm going to put my nursing quality hat on, and I have some suggestions. And as a clinician, I recognize that an individual that is highly activated is most likely to be successful post-rehab. And a successful post-rehab patient generally translates to a very positive patient satisfaction score and an individual who is an ambassador to your program. And Tara said that, right? She loved her cardiac rehab program, and she said, this is fantastic, whatever I can do to help you. And again, poster child for a highly activated, highly engaged cardiac rehab patient. And that's wonderful. And here's some simple ways that you can incorporate activation assessments and engagement activities to improve your program, improve your patient's outcomes, and then improve patient satisfaction with your program. And you can see that I've incorporated the 6 core tasks for patient activation to support into supporting activation for your patient, because you want to assess and then instruct in symptom self-management. You want to engage in actions to support their health. These are the 6 core tasks. Involve them in decision making. Make sure it's a collaborative environment. You don't tell the patient what you want to discuss with the patient, and then I get to choose what I'm going to do because it's my goals. And critical performance-based selection of providers and navigation of the provider system. So the pre-test becomes not just asking me my understanding of those 4 different parts of cardiac rehab, but also ask me what I'm now doing for exercise, because I may be doing something prior to my cardiac event, and then ask me if I'm satisfied with my current exercise, diet, or lifestyle to support my healthy heart. Because if I tell you I'm eating potato chips and I'm happy with that, then you can see that maybe diet may be an area that you may need to spend a little bit more time talking about. During orientation, we want to make sure that you look at my activation and help me establish my goals. And coaching, make sure I have clear goals on a weekly, a monthly, and then at the end of rehab. And then post-rehab, how am I going to fit this into my life? Because as a person who worked full-time, my staff, I mean, I got time off to go to rehab. They kind of had to let me go to rehab. But after that, I was going to be expected to start my day at 8 and end my day at 6. So how am I going to build this exercise regimen into that lifestyle that I know I'm going to have to go back to? And what referrals do I need? What will help me? And then the post-test, the same thing. And then I would encourage an exit interview, not only with those of us who successfully completed the program, but for people who dropped out, what worked, what didn't work, and then what could be improved. So you have that continual performance improvement philosophy as you're working with your program, because it's as important to find out for people who stayed with, like Tara and I, what we liked and what we would change. And it's as it is to find out from people who didn't make it through the whole program, what were the barriers? Why didn't they stay?
You know, I really believe that all of our attendees and all of us, we really want to provide a first-class, high-quality cardiac rehab experience within our communities. However, in order to do this, we really need to take the time to understand the populations that we serve. Analyzing your catchment area, looking at the geography and the demographics of the population that you currently serve or may be missing are really important steps to removing some of these barriers to patient access and completion of your cardiac rehab program. Understanding your geography includes, among other things, determining the zip codes that you serve, as this now allows you to determine other kinds of information that may be helpful. For example, from zip code data, you can determine what industries are present in your area and what transportation options are or are not available for your patients to attend your program. Looking at demographic data is also vitally important. Things such as age, race, ethnicity, gender, and other things. These are very important things to look at because they now offer a window through which you can discern the cultures that you serve, the languages that are spoken. And these are things that you need to take into account in order to individualize your program and offer really high quality to all these persons who are within your community. So if you want to increase your patient volume, if you want to cater to some of these marginalized patients, you need to be able to address and recognize some of these issues. Now, geographical and demographic factors do come under the broad umbrella of social determinants of health. And many of you know that social determinants of health are really the conditions within which people live their whole lives, right? These are things that impact health, and they may also create barriers to cardiac rehab participation. And so addressing these social determinants of health is really important to improve health, yes, but also to reduce some of the longstanding disparities in healthcare and improving the effectiveness of our program. You know, it's really helpful for me anyway to think about these social determinants of health in 6 categories. You know, economic stability. What is employment status of your patients? Do they have income, right? Do they have to work overtime? Do they have financial support? Neighborhood and physical factors. Where do they live, right? Is their community safe enough for them to exercise on their own? When you hand them that exercise prescription to go home and walk, well, is the neighborhood safe enough for them to go home and walk? Education, and Kathy touched on this. What is their level of literacy? Are we presenting materials to them that is appropriate for their level of literacy? Is there a language barrier? What about food? Do patients have access to food? Things we don't really think about. But remember, a patient who is hungry is really not going to be interested in joining an exercise program. Are there healthy food options for them, or do they live in a food desert? There are many community and social context factors. Are there support systems? Are they victims of discrimination? Remember, this affects how they interact with the cardiac rehab staff and also how they're going to perceive the recommendations that are given to them. And finally, healthcare, systematic factors such as insurance coverage, and also provider-related issues. And Tara's unfortunate experience highlighted some of those issues: problems with the referral system, problems with just communication within the patient's experience during their admission and during their follow-up visits. And so we must be aware of these factors if we're going to mitigate them. So now that we know what the social determinants of health are, we can now start thinking about some ways to approach these barriers and to overcome some of these barriers that affect our programs. The implementation guide that you will receive goes into much greater detail about using your catchment area characteristics to determine social determinants of health barriers and also ways to overcome these barriers. Your implementation guide also includes a self-assessment tool created by the International Council on Cardiac Prevention with strategies to overcome your program's top barriers. And so in conclusion, remember that social determinants of health need to be taken into account when you are crafting an individualized, relevant cardiac rehab program within communities. So when the cardiac rehab staff members take the time, it takes a little bit more time, right, to delve into these issues. But when you take the time to search for and identify these factors, then now you have an opportunity to mitigate some of these conditions. And it may be as simple as, for example, helping a patient who does not have access to food, helping them to locate social services that can help them with that barrier. Let me hand it back to Steve now to introduce the next portion of our program.
All right, thank you very much. And let's take those concepts and turn them into a specific instance that you, Dr. Bailey Brown, as well as Adam Streb, were involved with. So can you just share with us your perspective on how you figured out the need for patient ambassadors to do the care coordination work, and how you actually went ahead and implemented that, and how well it worked, and anything that you learned along the way?
Absolutely. So let me start, first of all, by just giving some background information on Rochester Regional Health. So Rochester Regional Health is a large health system that provides care in Western New York, the Finger Lakes region, and St. Lawrence County. There are 4 cardiac rehab centers, the largest of which enrolled 431 new patients in 2020. Now, our previous referral system depended on the outpatient providers to basically remember to put an electronic order in Epic for cardiac rehab when the patient presented for their post-hospital discharge visits. However, recognizing some of the limitations of that, many patients would fall through the gap with that system, we asked Adam in February of 2021 to be our inpatient cardiac rehab ambassador. Now, there are some programs, that have a phase 1 program, but our health system, like many others, do not have a phase 1 program. And that has a lot to do with staffing concerns. Being able to have a staff member go into the hospital is not always feasible for most programs, especially considering programs where the cardiac rehab is off-site. And so in order to streamline that process of care coordination, we asked Adam to be our cardiac rehab ambassador to give that provider level endorsement and to also place the cardiac rehab order on patients prior to discharge. In May of that same year, we further streamlined the process by implementing an automatic referral system to overcome a lot of the provider-related factors which drive disparities. Let me hand it to Adam now to talk a bit more about the program.
Thank you for everybody at Take Heart for including me in today's talk and giving me this opportunity. So why would you need a cardiac rehab ambassador? I think the biggest goal is to try to bridge the gap from enrollment or referral to enrollment in the program. One of the things that we had realized is that our schedulers brought to our attention was that oftentimes when they would reach out to a patient about joining cardiac rehab, they would say, well, I'd like to talk to my provider first before joining the program. And oftentimes provider office visits are incredibly busy, and cardiac rehab can just get left out of the discussion. So the goal is that with an ambassador seeing somebody in the hospital, it provides that initial contact from a provider. It could be, it doesn't have to be a provider, but that initial contact so that when patients are talked to after discharge, that they can make an informed decision about joining the program. I think the second benefit is to be able to serve as a resource for mainly the patients, to give them more information about the program and how the program is adaptable to them. A lot of patients' initial notion of cardiac rehab is that it's just exercise, getting on a treadmill, and that's that. But letting them know about the other benefits as far as nutrition and smoking cessation, stress reduction, and such, I think is good. I also think it's been beneficial to serve as a resource for other providers in the hospital. A lot of times they may not have might not know specifics about the rehab program, and in talking with their own patients, they may be like, "Oh, I'm not exactly sure if the program can do a certain thing." That I could either answer that question for the provider or come talk to the patient. And then I think one of the biggest problems facing our healthcare today is how overwhelmed the system is, and I think oftentimes the focus is on short-term solutions for this, but it's really important that we concurrently work on long-term solutions. And since cardiac rehab has been shown to be beneficial to keep people out of the hospital and healthy, I think this is a great way to help towards that. And then I think that the position has been beneficial in terms of spreading awareness of the program and access to the program for all. So I think it has been helpful in terms of trying to overcome some of those disparities that we've seen with cardiac rehab in particular. And I think of Tara's story there, that this is the exact type of thing we're trying to avoid, is hearing about cardiac rehab for the first time 3 months later. And then lastly, we have an automatic EMR referral, and sometimes technology fails us or there's updates in the system, and it's I think it's been helpful to just be able to monitor that to make sure it's running smoothly. So a typical encounter for me has been about 10 to 20 minutes with the patient. On occasion, it's gone longer. I think I spent as long as 40 minutes with a patient. I really spend as much time as needed. And one thing that's beneficial with our hospital census is it provides a brief description of why the patient is there. So it lets me easily identify which patients I should go see during the day and which patients would be qualify for cardiac rehab. So throughout my day, I'll go see those patients, and I'll give an enthusiastic presentation of the program to them. But not only them, I'll talk to any family member they would like. Just this week, I had somebody who said, "Oh, I really wish my wife was here to hear about the program." So I said, "All right, let's call her up and get her on the phone and put her on speakerphone." And we're able to, I just pretty much reiterated everything that I told him so that she would be able to have that information as well. I answer any questions at the end that they may have, and then if it hasn't been done already, I do place the actual cardiac rehab order, which then prompts our schedulers to reach out to the patient. And at the end, I do give them a brochure with our contact information just in case something happens. If something falls through the crack, they haven't heard from us in a while, they can give us a call to ask about when they can start. And I do document on every patient. In the documentation, I just try to make our schedulers aware of any barriers that I foresee for the patient, and maybe which location they're closest to and interested in, so that it hopefully saves them time. So I'm a firm believer that cardiac rehab should start in the hospital, and there should be limited gaps. So not only do I talk about the program itself, but I try to serve as kind of the first step for the program. So I do discuss diet with them, and I've come up with a handout regarding that with more resources that they can look at. I do have the patients, if they have time, since a lot of patients do have smartphones in the hospital, I have them access some of those resources while they're there and use that as productive time. I do talk about smoking cessation and at least an initial exercise discussion. And then, personally, I have a lot of genetic predispositions towards certain things, and have had other family members go through heartache. So I try to make it relevant for patients, and how it might be relevant to them to start something like cardiac rehab. And then I think this does, for the patients who are really not interested in rehab, that at least they got this discussion in, and I think that they could at least take something from that and use it for after they leave the hospital. This was overall very easy to implement. After Dr. Bailey Brown asked me to do this, I started the next day. And as far as trying to prevent heartache and other issues, that's why I kind of got into medicine. So this has been really gratifying. I think one of the keys is trying to find the right person for this, in terms of who is passionate about trying to prevent heartache for other people down the line, or maybe they have other reasons why they might get into this, but somebody who's definitely the right fit is key. I don't see everybody on our list, but I try to get to everybody I can. So I think the automatic referrals we have, and then educating other providers, has helped bridge that gap. And I think this could also be a shared position if needed. And then I'll hand it back over to Dr. Bailey Brown.
Thank you, Adam. It really needs to be the right person. And Adam is very enthusiastic, very motivated, and that really has made an impact. While we have not formally assessed the impact of the intervention in terms of percentage referral of eligible patients, we certainly have noticed an increase in our new patient enrollment, which began in March after Adam started his role, and has been sustained and likely bolstered by the switch to an automatic referral system. There's also been an increase in the average number of visits per patient compared with our average in 2020 and our pre-pandemic average in 2019. This program has really had a tremendous impact on the level of cardiac rehab awareness just among staff within the hospital. I've also received a lot of positive feedback from patients about the program. In fact, during my time rounding at Rochester General Hospital, many of the patients that I rounded on prior to their discharge would often remember talking with Adam, even though they would oftentimes not remember his name, but they remember talking with someone. And they were most times activated to engage with our cardiac rehab program after discharge. Now, with the good, of course, has come some additional challenges, as this process has generated an increased number of referrals to a cardiac rehab program. And so we've had to think of creative strategies to improve patient flow in order to overcome some of the backlogs that have resulted and delays in patient start time. So it is hoped that Adam's role in terms of care coordination can be further expanded to include actually scheduling the first visit prior to discharge. And this could be something as simple as scheduling patients to join a Zoom-based group orientation, which would also help to improve patient flow. It would be nice to expand this program to the other hospitals within our network, and that would involve just identifying motivated persons within those institutions who would be able to take on this role as ambassadors within those hospitals as well. We'd also like to expand our options in terms of virtual cardiac rehab options, which would also help in terms of improving the flow of patients through the program and overcome many of the barriers related to class size and staff shortages.
All right, thank you all very much for insights that are innumerable throughout the discussion today. And let me just turn back to Lucia. Lucia, as you listen to this again, if there were a point or two from it that you think are really important for the audience to take away from this, why don't you tell us what that are? And we want to also encourage the audience, if there's a particular insight that you saw during today's presentation that's going to be valuable for you, by all means, enter that into the chat so that we can see what it is. But Lucia, what's top of mind in terms of the most important things that you heard today?
I think that one of the most important things is getting everyone on the same page and getting all the team members across the organization involved and aware of what cardiac rehab does, how we can help the patients that they have taken care of, and that it's the best practice and it's the next step for these patients. And I feel very happy with what we've been able to accomplish, and it didn't take a lot of work. But certainly getting an electronic learning, so an e-learning for all the team to be aware of how cardiac rehab can help their patients. And then, our presence in our rounding is good, getting a cath lab champion, but again, just so everybody's on the same page. But now the cath lab's more excited because they're seeing, oh, we can talk about cardiac rehab. So they have that to offer the patients as well.
All right, thank you all very much, and thanks to you in the audience for participating in today's training. Just looking ahead, we want you to continue working with your team, determining your patient activation levels and how you can enhance that over time. And we especially want you to pay attention to the Module 9 implementation guide that was referenced by the presenters today. And we think it's a really valuable resource that can help you think through this topic, make sure that you're not overlooking ways to better activate your patients. And then in the next peer action group meeting, we want to encourage you to discuss this and raise questions, come with insights or questions or challenges, and discuss them with your peer action group lead. Next up and last up is on Wednesday, August 10th, Module 10. And this is a special one focused on remote and hybrid cardiac rehabilitation. So if you're thinking about, or you should be thinking about, another option to better serve some of your patients, by all means, Module 10 is going to be extremely invaluable, and you can use the link to sign up for that. So thank you again to our presenters, to Lucia for her insights, as well as to all of you for being in attendance today. We hope you have a great month, and we look forward to reconnecting with you in August.